Good afternoon, everyone. Welcome to Brahm Center's Health Webinar. Today, we have the privilege of inviting Dr. Jerome Goh, who is the Principal Forensic Psychiatrist from IMH. And today, his talk will be about symptoms and treatments of depression. Brahm Center do offer counseling and mental health assistance in English, Mandarin, and even Malay. So if you have friends or relatives who are in need of help, please contact us. Dr. Jerome Goh, how are you today?
I'm good. How's everyone?
I think they are all good, Dr.
Yeah.
Goh. We have today 132 attendees already in the webinar room. So Dr. Goh, kindly proceed. Thank you.
Okay. Thank you. Right, so today I was asked to talk about the symptoms and treatment of depression, right? By way of background, I'm actually a forensic psychiatrist, but I do treat primarily patients, adults, not so much children or elderly. But depression is something which is very common. And I hope by this sharing that we'll be more aware of what are the symptoms when is somebody having symptoms of depression and what are the options that these people have. So I want to first emphasize that we have to make a distinction between what is normal before we can tell what is abnormal. When we talk about psychiatry or mental illnesses, we usually think about perception, a person's thinking, emotions, and self-control. Okay, so when we say there's an illness or there is a disorder, invariably it affects one of these domains: how people see things, the way they think, their regulation of emotions, and self-control. So a lot of it, you might say, is relative. Okay, so is it a mental illness? When it is character in the cartoon, he says that I'm very, very happy, but I want to be very, very, very happy. And that's why I'm miserable. I wouldn't call this depression, because to be a mental illness, it has to be more profound, more enduring, and more severe. So it's usually an illness when there is a lot of distress that is experienced by the individual. And the ability of the person to function in day-to-day life is very much reduced. So we're talking about things like school, interpersonal relationships, functioning in the family, and at work. So besides this, there's usually, for each condition, a set of signs and symptoms. We call it in a medical sense. Okay, what are the things that the person can report, and what are the things that the people around them observe? It's actually quite common, depression, that we realize. This is from a most recent study in Singapore, the second Singapore mental health study, which was started in 2016 by IMH in collaboration with our MOH and NTU. So as you can see, the major depressive disorder, or rather depression, okay, there is about 6.3% lifetime prevalence in our population. So imagine 6 out of 100. That's quite high. Of course, there are other conditions as well, and sometimes these conditions may coexist together. For example, somebody who might be depressed or anxious might also be using a lot of alcohol. And sometimes they also present predominantly with anxiety type symptoms. So I hope in the subsequent slides, I can give you an awareness of what kind of symptoms a person experiences in depression. For depression is actually something that most people can relate to easily. Okay, when you say that I'm depressed, generally you feel some of the symptoms that I'm going to describe subsequently. But the only difference is that in somebody who has clinical depression, all the things that I will describe, the signs and symptoms, are not just fleeting. They don't just come and go in a day. They usually last for days on end, throughout the day, for a prolonged period, and we're talking about more than 2 weeks. Then we consider this to be something that needs to be managed and treated. So obviously, something that we are all aware of is in depression, the mood is affected. Very specifically, the mood is low, they're feeling sad, they might be tearful, and sometimes it comes without any trigger. So for the rest of us, generally it's understandable and normal that when there are things that happen that didn't go our way, we'll feel low, we'll feel depressed, we'll feel disappointed. When a depressed person, this may come out of the blue, it may be present most of the time, and it's very distressing for them. It affects motivation and interest. Okay, of course, motivation is something that we sometimes wish we had all the time when we are studying or when we're working. But in somebody who is depressed, it's not something that can be very easily to happen here and now, because there's usually a loss of interest in the things, in the activities that people used to enjoy. We're talking about a person's hobbies. If they like music, if they enjoy dancing, seeing shows, if they enjoy the company of their friends and loved ones. When someone is depressed, all this change. They find that they had no further interest to sit through a social interaction. Some individuals I know, when they are depressed, they actually participate less frequently. For example, if they love soccer, they wouldn't go as much as before to play. They wouldn't mix their friends as much. They turn down the request. And this is quite understandable because as human beings, when there's something that we enjoy, it has a reinforcing effect. It motivates us to seek more of the same, something that we find rewarding. But if you have no interest at all, you hardly want to try any of this. So for someone who enjoys shows or music, okay, perhaps maybe just talk about watching shows. In their normal self, they would sometimes they even laugh along, kind of like in a way participated in the show as in having emotional reaction, sadness, anger with the characters, or humor, laughing at what's going on there. But for someone who is depressed, this is very different. It's just like sitting through passively without any reaction. And sometimes after a while, they'll find that this is really too much. I don't really enjoy it. I want to stop watching. Okay, so you find as a result, most of the time they would end up doing probably nothing much at all. It's hard to persuade them to go out, to do the things that they enjoy, to do things with others. So any type of hobbies. So usually a good guide when I'm reviewing someone who comes with such problems, I would generally ask what are the things that you like to do to relax and to enjoy. What do you find relaxing? And when's the last time you do it? Do you do it as much as before? And even if you do it, do you enjoy it as much? Okay. So it can be, as I said, reading, drawing, playing the guitar, cooking, sports, photography, cycling, singing, and so on. Okay. So it is very debilitating because it takes the joy out of life. And of course, people who are depressed have sleep being affected. Okay. And we're talking about the cartoon on the right side. All right. They will lie in bed most of the time, toss and turn, unlike somebody who sleeps soundly, who wake up refreshed. So people who are depressed generally present with a few patterns of sleep problems. The first of which is they have problems falling asleep, which means they can lie in bed for hours before they finally knock off. all right? And the second type of sleep problems you often see is people will often wake up intermittently during the night. So that it doesn't feel a very deep sleep. They woke up very easily to for example, the slightest sound, and sometimes even without such disturbances in the environment. And for some of this, the third type of sleep problems is being seen, where when they wake up, they have problems going back to sleep again. So they may, for example, get up about 3, 4 a.m. when normally they would wake up normally at 8, and they can't fall asleep for the rest of the day, or rather the night. Okay, so having problems falling asleep for a few hours after they woke up in the middle of the night. And this causes a lot of problems, obviously, because we know that sleep is restorative. It's during sleep that the body heals itself. The brain processes maybe what has happened during the day before. It calms the body. It builds up your immunity, and all this can be problematic if sleep is affected. We know somebody who lacks sleep generally will be very irritable. They will have problems with their focus and concentration. Okay, all of us invariably may have this kind of sleep problems for a day or two, and you realize that the next day when you have to go back to work, you make mistakes when you don't often do. You forget things. You have problems organizing stuff. Okay, so you are basically much worse off than before cognitively. And depression also affects the way we see ourselves, the way we see the people around us, and how we see the future. So these are called depressive symptoms, feelings of guilt. Okay, and it's not something that we had transient feelings about something that we did, which goes away. In depressed people, the feelings of guilt last, again, most of the day, almost throughout the day, for prolonged periods. It's not a fleeting sensation or feeling. They feel guilty about what they may have done, even though these are, by most measures, very minor transgressions, if we call it that, against ourselves or against other people. They have problems with self-esteem. They generally feel very worthless, that they are incapable, useless, not contributing, a burden to other people. And this can be then really sad. And when they look at the future, they feel very hopeless. So it is looking forward and saying that there's nothing in front of me, there's nothing for the next day, there's not much meaning in continuing to live. Every day is the same, every day will get worse. So imagine this generally, these negative feelings about oneself, about your self-esteem, about the people around you, being unforgiving, being too harsh, and about the future. And of course, you know that depression, sufferers have problems with low energy. They feel lethargic. Okay. How do you know that is a difference from normal? Okay. So if somebody can carry on the day with no problems at all, and suddenly finds that for days at a stretch, before the middle part of the day is gone, he's already exhausted. He can't go on working. He really has to lie down most of the time or take a break here and there. So this is what we call lethargy. And when it is extreme, it can be very, very disruptive. Okay, so in psychiatry, we have a term for that. So it's generally, how do I put it? It is feeling much less energetic than what you normally would. And symptoms like lethargy, sleep problems, all this can be considered as a biological state. It's not something that you can actually will to go away, that I want to have a better appetite, I want to have better sleep, I want to have better energy or better concentration. Okay, so some of these symptoms, what we call biological symptoms, may be better treated with medications, okay, rather than psychological intervention. There's a place for psychological interventions, which I'll talk about later. And of course, we know that depressed people have problems with forgetfulness. They can't focus, they have impaired concentration. And it is really the more intense you need to focus on a task, okay, the easier it is to spot this kind of problems. For example, like typing, okay? If something that you have to maintain second to second awareness of what you're doing, this tends to cause the most problems. Sometimes people who are depressed may be able to get by because much of their routine, much of their work doesn't require that level of focus, intense focus, okay? So this doesn't mean that they may not be depressed. When they have to do the tasks as I mentioned earlier, like typing, having your eye on the goal, for example, in counting things, the line of their work, this can actually be a big problem. For example, having to recount again, did I forget this? Having to redo something because something which they forget. And it affects the appetite. So most people with depression, I would say most because they would have less appetite. It's just that it's not just the food being not nice, but what they used to like to eat. They find that it's bland, it's frivolous, there's no desire, they already felt full after a couple of mouthfuls. And generally, this is associated with loss of weight. So they'll lose weight gradually, continuously until something is done, or until their mood is better. In a tiny proportion of individuals with depression, we find this, or surprisingly, they may end up eating more and sleeping more as well. Okay, so generally, I think these are perhaps more seen in younger individuals where they may, if they're depressed, they may sleep more, sometimes they may eat more, but you can see other symptoms, which is impaired concentration, lethargy, and so on. Okay. For depressed people, for those who are extremely depressed, we realize something very striking, is that they tend to talk very slowly. They respond after a long pause to what you say to them. Sometimes the train of thought trails off. They forget what they're going to say. You find that they often will ask you, sorry, what would you try to ask me just now? After a couple of seconds. So this kind of slowing down of the thinking, slowing down of the speech, flat, monotonous voice, slowing down of the movements. They walk slowly, they do things much slower than before. The term that we in psychiatry use is psychomotor retardation. Okay, psycho means mental, cognitive, motor as in movements. All these are slowed down. In some individuals, it is the opposite, where depression sometimes generally causes anxiety, and they feel very restless. They tend to move around a lot, and there's a sense of tension. Okay, the psychological tension that they feel ill at ease. So that is a symptom too. Because the most worrying for families, for healthcare providers, is when depression affects a person's perception of life meaning and purpose. So when someone feels that life is meaningless, that everything is so bland that there is no point going on, might as well die. And in some individuals, to the point of contemplating whether suicide is an option or even planning for it. So this is also one of the sign and symptom of people who are depressed. Okay. In severely depressed individuals, this would be a symptom I would say in those who are severely depressed. when it comes to that stage, and they should get assessment and help sooner. Okay. So when we say somebody who is depressed, doctors may like to classify them as either mild depression, moderate depression, or severe depression. This is really a few things that we consider. I just mentioned the 9 symptoms of depression. Okay, the number of symptoms, obviously, the more they are, the more we consider severe depression. The severity of the symptoms, sometimes the symptom itself, like suicidality, is severe enough, we could consider that. Some of the symptoms like impact concentration, if it's really bad, we would consider that as a severe symptom as well in terms of the spectrum. Okay, and the duration, the longer it is, of course, we will consider it as a more severe form of depression. So the number of symptoms, the magnitude of each of the symptoms, how it affects their life, day-to-day lives, and the duration. Okay, and because depression is a treatable condition, it shouldn't be the case where an individual has to continually suffer the stress, particularly of a severe nature, and they should be brought to get help, professional help, as soon as possible, particularly if they are thoughts about self-harm. Depression affects people more than just the symptoms that I described. Okay, this graph is called a Yerkes-Dodson curve. It is the relationship between our level of arousal and performance in the task. So when we are highly motivated, when we're very aroused, such as before at a sports meet, at a competition, performance is at its peak. When people who are very anxious, even if they're highly aroused, performance starts to drop. In depressed individuals, it is the opposite. When you have very low motivation, you have problems with staying focused, you don't want to move much. What I described earlier as psychomotor retardation, motivation is affected, movements and thinking are affected. It actually affects a lot of things in their lives. Okay, for example, studying. What I earlier described as an example of a task that requires second to second, minute to minute focus, like typing. You find that a lot of mistakes are made with that. And in driving, for example, and it can cause problems with the individual's life and others. So depression is a mental illness, but there is a link. For most mental health conditions, there is always a link between mental and physical health. We know that for somebody who has depression, if it is poorly treated or not well treated, their current comorbid physical conditions like ischemic heart disease, their pain disorders, the prognosis for these illnesses are generally much worse. There's no clear link or reasons why the physical condition is we don't really know why they are much worse. It may be that diet is affected. We don't look after our eating habits that well. We are not really in the mood for anything. We may not have exercised as much as we should. We may have picked up bad habits like smoking and drinking to cope with the negative emotions inside us. But we find that in terms of lifespan, in terms of the functioning, all these are affected. The physical illnesses like the heart conditions I spoke about, the chronic medical conditions, cholesterol or high blood pressure, all this can be affected by depression. On the opposite side, some physical illnesses, some physical diseases or illnesses can cause people to be depressed as well. And conditions like chronic pain disorders like rheumatoid arthritis, okay, somebody who is in constant pain, very severe skin conditions like psoriasis, okay, can make a person depressed because it's something that they have to deal with day in and day out. So why do people get depressed? So in psychiatry, in medicine rather, we generally divide the causative factors into bio, psycho, social domains, the biological factors, psychological factors, and social factors. Social factors. So our mood are affected by what happens around us. Life events are acute incidents that requires us to change the way we operate, sometimes change our belief systems, and require a change in coping, better coping to deal with new situation. So there are at the extreme, very negative life events like the death of a close one, family member or friend, a loss of a job, a recent diagnosis of severe physical illnesses like cancer, and so on. So then maybe more minor ones have problems at work, even moving house, problems with finances, and so on. So all this can be the trigger for low mood. And if the symptoms that degenerate is persistent and enduring, depression can sometimes be diagnosed in these people. Next is biochemical, biological. In depression, there's an explanation why antidepressants work. Okay, these two are pictures of a neuron, a nerve cell in the brain. Okay, so they're called neurons, and in the brain, messages are transmitted by what we call neurotransmitters. So these are you can consider as proteins that help to transmit messages from one nerve ending to the next. Okay, so monoamines are there are two kinds of chemicals called norepinephrine or noradrenaline and serotonin. So this is in the brain, and we find that in individuals who are depressed, there is actually less of this to go around, these two neurotransmitters, norepinephrine and serotonin. So it is the basis why drugs work, and drugs work well. Because in the normal individual, some of the neurotransmitters that are in the space between the two nerves, we call it the synapse, are being taken up from where it was secreted from. So they're taken back into the nerve itself, and they are destroyed by another enzyme we call a monoamine oxidase enzyme. Okay, so one protein complex will reabsorb back these neurotransmitters, and another protein complex will break it down. So how antidepressants work is to stop the reuptake. Okay, to stop the reuptake of this neurotransmitter back into the neuron that secretes it, and to stop the destruction of these neurotransmitters. So this is a very crowded slide. So you will see that different classes of antidepressants work on this principle. For example, you have the selective serotonin reuptake inhibitor. Okay, just now I was talking about the protein complex that takes back the serotonin and the norepinephrine to be broken down. So it stops that, it blocks that. So there's more that is left behind to be transmitted in terms of the message to the next nerve. Okay, there is serotonin norepinephrine reuptake inhibitor, is the same thing. And then we have the monoamine oxidase inhibitors. This is the enzyme complex that breaks down norepinephrine and serotonin. Okay, and a lot of these drugs are very effective to treat depression. The caveat is that unlike other drugs that we might know, it is not instantaneous. You don't take one, you don't pop a pill, and you feel much better after that. That's because it works differently in the brain. The drug has to go into the brain, it has to cause some changes in the protein complexes, in the nerve endings, and this can usually take up to 1 to 2 weeks. Some of the drugs like escitalopram, okay, for example, in the first week, we may see a reduction in anxiety in those who are depressed. In the second week, we'll start to see the depressive symptoms get lesser and further improvement after that. In fact, most of the drugs that we see here, generally, you see improvement in their mood. Okay, the mood symptoms get less, their mood improves, they sleep better, they eat better after 2 weeks of continuous ongoing use. So this is not the same as what you might expect from high blood pressure medication, for example, that you take, your blood pressure goes down. There has to be a certain level of, persistence and belief that the medication, if taken continuously, will lead to a better mood. There would be medications with side effects. All medications may have one kind of side effects or other. And that is not the reason to stop the particular medication. It's always better to bring the conversation back to the prescribing psychiatrist and tell him that, look, I have this problem with, for example, there's always, as you can see here, another type of antidepressant that may have a slightly different side effect profile that is more agreeable and tolerable to the person taking it. Okay, so don't stop because of the side effects. For example, some medications like Remeron, or what we call mirtazapine, has a very marked effect on sleep. It causes people to be very sleepy when they take it at night. And it increases the appetite a lot. Okay, I wouldn't call that a side effect because in some people, depression causes the appetite to nosedive. They eat so little, so maybe a little bit more appetite is good for them. So it's actually, I think it's therapeutic. And because of the sleep problems people with depression invariably have, a drug like Remeron or mirtazapine is actually very good for night sedation. But imagine if this is somebody who needs to stay focused, okay, at night, perhaps because he's driving, he has to do night shift sometimes, and we have to respect that individuals may have preferences for what they expect and what they do not want. Okay, younger, for example, might be very conscious of the weight, and Remeron would, because of his increase in appetite, would not be a good idea. Okay, because it does really, it can cause quite noticeable increase in the weight. And for somebody who has high blood pressure, high cholesterol, or diabetes, again, a drug that causes too good an appetite would be a problem because all these conditions can be worsened by too much intake. For other individuals, they may be quite conscious of side effects like sexual side effects. It's important to them. So as the mood gets better and everything gets better, they will expect more social connectedness. And this is really something that is undesirable. So there are other drugs, as I say, and one of which is Wellbutrin, which has less propensity to cause sexual side effects. Okay. So I didn't talk so much about tricyclic antidepressants, which is a kind of older generation of drugs. It can have quite a lot of side effects. It's kind of a dirty drug that has a lot of receptors. Some people might get sedative, too much sedation, blurring of eyes, dry mouth, difficulty passing urine, difficulty passing motion even, and heart problems. And it can be a risk sometimes. We don't usually prescribe that. We generally move more or less towards what we call SSRIs. Most of you will have heard of Prozac. Okay, it's actually in the SSRI class of drugs. Or SNRI, serotonin norepinephrine reuptake inhibitors, all the newer drugs. we don't give so much of monoamine oxidase inhibitors or mild MOAIs nowadays, because there was a lot of problems with drug interaction, particularly with fermented foods. For example, those that contains tyramine, fermented cheese, and so on. Okay, and so the kind of meat products. So most of the antidepressants that we are using at SSRIs have very mild effects. It's not risky in overdose. It doesn't cause too many side effects, and they're generally quite well tolerated. So psychological factors. How we think sometimes affects how we feel. So there was a experiment where basically putting a dog in a kind of a setup like this, where one side, where there will be periodic electric shocks being administered. And if the dog feels that no matter what I do, I cannot escape the situation, the shock will still come, I can't get out of the situation, the animal actually got into a kind of a state that mimics depression in human beings. It stopped trying to escape. It's very apathetic, immotivated, very little movements and very little spontaneous expressions. Okay, but if you actually make the animal feel that by doing something, the circumstances can change, this wouldn't be the case. It's actually the belief that we cannot change the cause of negative events, that failure is inevitable, that sometimes aggravates the feeling of helplessness that you see in depression and may actually worsen the low mood. Okay, so it's really talking about locus of control, that for somebody who feels I control my destiny, is probably more empowered and happier than the next person who feels that other people control my own destiny. So this actually is the basis for psychological interventions. In depression, a common intervention is what we call cognitive behavioral therapy, or CBT. And this is how it works. But the way we think affects the way we feel. So you appreciate that sometimes when certain things come up suddenly, we have a automatic way of thinking, like jumping to conclusions. Basically, this is related to our experiences from the past, our beliefs, our attitudes, maybe our preferences or our biases that leads us to think in a certain way. And it's another set of thinking which is more deliberate, rational, and self-conscious. So imagine if you see a picture like that, it generates some kind of emotions, I hope positive ones. If you are in an event like this, you either feel that I'm going to hit the ball or I'm not, and it can make a lot of difference in the performance when you're studying. Or if you're in the plane and suddenly there's a lot of air turbulence. Okay, someone might stay calm, but for another next to him, there might be a catastrophic reaction that, oh, everything is going to end right now. We're in a lot of trouble. So this is, you might have seen this before. Okay, this is just to demonstrate that sometimes our brains are wired to work in one way, which is not very productive. So can you try to read the words as they are, okay, and not name the colors as fast as you can? Okay, just read the words as they are and not name the colors. Most people would have a lot of problems with that because we are wired to think in a certain way. Okay, when two sets of instructions or competing priorities come by, we are very distressed, if I put it that way. So it's all about, in a large way, choices. Okay, so psychological interventions may help in problem-solving abilities. It may help to clarify what you can do and what you might have to accept. And of course, this has to work hand in hand with biological therapies, as I mentioned earlier on, like pharmacological treatment. Because in order to analyze well, make decisions well, there has to be a certain competency in your attention, your focus, your thinking skills. So I thought there's no better way of putting it than this. Okay, what Viktor Frankl, who is a psychiatrist and a Holocaust survivor, he said, between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. So inherent in this is the issue of choice and the issue and the challenge of seeing difficulty of a problem as an opportunity for growth. Okay, not something that is there just to hurt us and make our life difficult. So when somebody is going through psychological interventions, we would generally explore things like problem-solving skills, creative thinking, maybe assertive expression, negotiation and social skills, managing emotions, critical reasoning, and so on. Okay, so I'm talking about psychological interventions where there's it can be sometimes can be in groups. More often it can be one-to-one. In the CBT that I mentioned earlier on, it's generally one-to-one for perhaps 10 to 15 sessions separated by weeks apart, and there's homework in between. Okay, so you really want to move away from someone who acts like this to somebody who acts like this. Okay. So how we think affect how we feel. So this is from a book that I will show in a subsequent slide as an example. Okay. So suppose you're at a party and a friend introduces you to Alex. As you talk, Alex never looks at you. In fact, throughout your brief conversation, he looks over your shoulder across the room. Okay. So what would be your response? How would you feel? Okay, if you're thinking that Alex is rude, is insulting me by ignoring me, obviously you will feel angry. But the next person, somebody maybe with a different perspective, might think that Alex doesn't find me interesting. I bore everyone. Okay, obviously he will feel sad. He or she might feel sad. Or if you think that, oh, Alex is just shy, he's probably too uncomfortable to look at me. Okay, so the different kind of response here, and this person will probably feel a sense of caring and empathy and that. So this is really sometimes the programs, I would say the programs that is inside each one of us that pre-program us to think in a certain way when the same situation arises. Okay, the same situation can therefore generate different responses and different emotions in all of us. So this is really the basis of and maybe the purpose of CBT, psychological interventions like CBT, that sometimes there are cognitive distortions, how we see the world, or I guess our pre-programmed attitudes. Okay, if they are too dysfunctional, they might need to be nudged into a more functional mode. Sometimes people may be overgeneralizing. They make sweeping conclusions about yourself being useless, about the others being too harsh, for example. They might magnify things, they might focus on a small aspect of perceived failure and say that as a result, I'm really, really useless, or this is evidence that something is really, really out of control and I'm unable to deal with that, and so on. So, and this is a book that I just talked about. This is a bit different from the one-to-one counseling I talked about in the sense this is a book. So it's kind of a self-help with a lot of exercises in between. So I think it's kind of quite fun to actually go through that. CBT generally works best in individuals with depression or anxiety. Okay. So to coming to the end, depression key facts, and I take it off the World Health Organization website. There's a fact sheet on depression. It is a common mental disorder. Okay, globally, more than 260 million people of all ages suffer from depression. Depression is the leading cause of disability worldwide and is a major contributor to the overall global burden of disease. There are more women affected by depression than men. Depression can lead to suicide. And the good news is there are effective psychological and pharmacological treatments for moderate and severe depression. Okay, and resilience is really about bouncing back from failure. There will never be anyone with no failures in their life. It's really about how fast a person can pick himself up and keep going and keep trying again. So earlier we talked about social factors that may contribute to depression. And this is something we could do prophylactically before something bad happens, is to maintain constant and caring, supportive relationships with the people around us. Okay, particularly in this circuit breaker period of COVID-19, we may not be able to see the people we love and care for as much as before. But it's nothing to say that we can't give them a call, or like now, do a kind of a Zoom video conferencing with other family members as well. Okay. So I'll just end with this slide. This study done by a group in IMH as well on the positive mental health instrument. 6 things that contribute to positive mental well-being. Okay, what's a person's general coping style, the amount of emotional support that he or she can get from the people around them. Spirituality helps. The skills to deal with stress, relaxation helps. Problem solving too. Personal growth, the opportunity for personal growth and autonomy, they do feel like they learn helplessness situation I described earlier in the experiment. And how a person generally display himself or manifest is the day-to-day demeanor. So globally, that helps a lot too. Okay. There's one video, I'm not sure whether I can play it, but I think this is also from the World Health Organization website. I had a background, his name was depression. It's actually quite worthwhile, I guess, if you're trying to remember all that I said earlier on. This 4-minute video would actually summarize it very well in a very memorable way that you will remember what is important. If you didn't remember it, that's what I said earlier on. Okay. So I think I'm okay to take questions now, if there's any questions.
Dr. Goh, thank you very much for sharing with us. Indeed, we have many questions. Yes, we have 220 people actually attending this talk. Yeah, so thank you so much. So I'll voice some question to you. Is there a particular age group that you see more cases of people getting depression?
I think generally we see in clinical settings, depression to be more common in the, I guess it's the 20 to 30 is one of the blips. That could be related to a lot of things like changing from formally studying to working, starting out in line of work. And when that happens, they're generally the smallest fly, the one who has least control over things, and having to think at the same time of other life events like getting married, settle down, getting a house, paying for the house. So there's a lot of things that is required, a lot of expectations, but very little power to change things. The next break that we sometimes see is in the elderly population. So this could be related to the onset of physical illnesses. So as I mentioned, sometimes things like ischemic heart disease, cardiac problems, chronic pain disorders, chronic skin conditions can cause depression, and added to that could be social isolation in some of the elderly. Could be the empty nest syndrome when the children have already grown up and left the home. So there's a sense of loneliness. For individuals who are, I would say, healthy, relatively mentally, psychologically healthier, they adjust to these changes better. They have a sense of fulfillment that I have contributed, my children has grown up. But for some, they may not have that kind of fulfillment, and they felt kind of lost, kind of stuck, and unfulfilled generally.
Thank you, Dr. Goh. How do we convince someone which have symptoms of depression to seek diagnosis or treatment?
I guess in depression, it could be, I think it could be easier compared to conditions like for example, schizophrenia, where they have lost touch with reality. In depression is something that we can tell if we are depressed, we can feel it, we are distressed by it. The person will be suffering and he wouldn't feel good. So if you say, I don't think, if you notice that this person is not coping well, he or she probably knows it too, that I'm not doing well. The difference in how really they like to seek help is their mindset that this has always been the case, this will never get better. So it may be good to actually instill some hope. Okay, as what I was trying to emphasize during this short talk is that there are effective treatments. Okay, even if one doesn't work, the next one will most likely work, and the next one. And it's not just one treatment. It can be a combination of treatment as well. And all this has very good evidence base. So this is further academic. And then it's finally to think about the different reasons why people might be depressed. So we talk about medications. Sure, it helps to make sure that they take their medications every day, ongoing for almost 2 weeks. Okay, before we see that this is not working and I want to stop it. So give that sense of maybe it helps to have some kind of reminder if they eventually are persuaded to try medication, and supervise their follow-up. So if they have to see a doctor for the next follow-up in a couple of weeks' time, maybe just encourage, nudge them, volunteer to drive them there and accompany them there. That all this helps a lot. Okay. There are social factors as well. Life events, like bad things happen. Sometimes it's like a lack of close and nurturing relationships. It may be just being there to listen, rather than being very willing to give advice. I think listening is very important. Sometimes just being there helps a lot already. When people change is often not because of how strong your argument is, but what kind of relationship you have with them. So the better the relationship, people are more willing to acknowledge that this person really cares, and maybe I should listen to him. It's not the kind of cognitive level. And psychological interventions, I guess, would help. That requires some commitment too. Much like medication in CBT, for example, it's really about going for one session and the next. So I had a tutor or a mental health who I respect very much, who says that we know why in business when the patient comes for the next appointment. So it's really about the level of commitment to get ongoing treatment. And sometimes before they're all the words, they need a lot of reassuring that things can be better. And when talking about 2 to 3 weeks, these are improvements. Okay, so I would just want to say that there was one extreme when persuading might have limits, and maybe we might need to act more urgently. I mentioned one of the symptoms is actually the perception that life is very meaningless and feeling suicidal, and these people might need more urgent linkages to services. And of course, we have IMH, we have hospitals. Essentially, all the hospitals in Singapore would have a psychological department. I think getting care early is very important in this case.
Thank you, Dr. Goh. Absolutely agree. I think based on many research, the earlier that the person seek even counseling or some checkup, the easier and the faster the recovery is. As you were answering that question, I actually ran a poll to our audience, asking them do they know someone who is having depressive symptoms, and we have an astounding 74% said yes. So I think, like what you suggest, if we notice our friends, our relative, or even ourselves having such symptoms, the best thing we can do is to maybe give them a little bit of love and care, and maybe guiding them to some help, like our Brahm Center Assist Line and counselors, and take that first but difficult step. And once that step is taken, I think the rest of the steps will become a bit easier.
Yeah, agree.
So Dr. Goh, how do we tell a person is mild, intermediate, or deeply depressive?
Okay, so in psychiatry, we divide the severity into mild, moderate, and severe. Generally, this is on the 3 criterion. One is the number of symptoms. So in depression, we know that I'm just going to talk quite fast because I'm quite familiar with it. Sleep problems, loss of interest, feelings of guilt, hopelessness, loss of energy, feeling lethargy, impaired concentration, forgetfulness, poor appetite, loss of weight, psychomotor retardation, and suicidality. So the more check boxes you find, generally this will be more severe. The next thing is the severity of the individual symptoms. So they may have less than the next person, but one of the symptoms can be very bad. For example, they might have so little appetite that they're not eating much at all. They may be just water, maybe just fluids. They're losing so much weight. They are so forgetful that they tend to get themselves into accidents or forget things that causes big problems and lost their job because of their forgetfulness. They're so lethargic that they hardly get out of their room. So even if they have a couple of them, but not others, I would consider them as severe symptoms as well. And finally, is the level of risk. Okay, and people who are depressed, there are some unfortunate individuals who feel their life is no longer worth living and thought about ways and means to harm themselves. And obviously, those who are suicidal would be in that severe category. In a small minority of depressed patients, they have psychotic symptoms in which they lost touch with reality, and these are also severe symptoms. Okay, psychosis in depression is different from psychotic symptoms in schizophrenia. Generally, in people who are depressed, their lost touch with reality belief is usually about I'm going to die, I have a serious cancer, when that's not true. Things is rotting inside my body, which is not true. So there's something related to a depressive theme of ending, life ending, and no more hope.
Dr. Goh, is there a link between depression and dementia?
I'm not aware of any research that shows there's a clear link between depression and dementia, but sometimes both conditions are associated with stress. And in somebody who is depressed, generally the stress that you may have from a certain event, like passing of a close one, for example, will be much more than the next person who doesn't have depression. So when you are depressed, generally the problems are heavier, the problem seems bigger, and your coping is definitely poorer. Okay, and when there's a lot of stress, generally it affects the brain, and there are problems as a result. And it can be something in the body that affects your general health as well. So I think it's very possible that people who are depressed, it can affect the dementia or the progression of dementia. But bear in mind that the dementia itself sometimes is associated with depression as well. somebody who is dementing, it is a scary situation where you start to lose memories of what you treasure most. You forget the names of people, you forget where you put things, you spend much of your time looking around for things that you thought you put there, and it causes a lot of stress and you end up being depressed.
Thank you, Dr. Goh. Dr. Goh, there could be people who are, what we sometimes call melancholy, that's maybe their personality. So how do we tell if that person is just melancholic or, in the depression, having depression symptoms?
Right. I think to some extent, melancholy is something that, okay, I would say that for everyone will experience their moments of melancholy. Okay, life is never a bed of roses. We expect challenges in our lives. But for these moments of melancholy, they are transient. So when the situation that causes it is no longer there, we get out of it by ourselves without any external help generally. But when you have all the symptoms of melancholy, like low mood, and you throw in, I have problems sleeping as well, I have these problems of depression, of cannot concentrate, and it lasts throughout the day. It doesn't even get better when the problem goes away, and it lasts for weeks, and I cannot work, then it's depression.
Thank you, Dr. Goh. Is there a trend or cycle when a depressive patient, so a person who has been diagnosed already, to go through this cycle of mood swing maybe every 2 to 3 weeks?
So it is possible that people who have depressed symptoms, sometimes they what we call mood swings. I just want to mention that it's very possible those who are depressed can also have episodes of abnormally high moods, okay, for a sustained period, and that is obviously sounds like a disease condition. We call it in psychiatry bipolar affective disorder. People who are depressed, sometimes they can be at higher risk of having manic episodes where their moods are high or irritable. So the depression may just be a down episode or what is a down and up episode of bipolar disorder. So it is possible. So for some patients, the depression, sometimes the mood has so much changes of ups and downs for discrete prolonged periods that is not a normal up or down. For melancholy that we talked about earlier, or elation at getting a promotion is not a normal this kind of reaction. Then there's conditions called psychothymia as well, which is a rapid kind of movements of mood in either direction.
Thank you, Dr. Goh. For people who are taking antidepressants, would they need to take this throughout their life?
The short answer is it depends. There are people who I've treated quite a few who actually has been well enough to tell me that life is much better. I've gone back on track. With the antidepressants, I have more sleep, better sleep, more energy. I managed to solve my problems more efficiently and effectively. I no longer need medication, and they have cut down the medication and stop it. But I would say for a group, when there's more than one depressive episode, generally the treatment should be longer term. We call it maintenance treatment. My way of persuading these people is that you do really want the next episode to strike. You're now taking this more like an insurance where the next episode will be much less likely to happen. Because when you're depressed in the midst of a job that you enjoy and value, and your boss find that you're unable to work, you might end up losing that job, and it's really not worth it rather than taking a medication that doesn't cause you side effects. So for this, I would say majority of my patients tends to be on medication on the longer term. There are some who actually had a very difficult time coping with loss and bereavement, and they end up getting depressed, and sometimes they got better. It's a lot about individual resilience as well. Some individuals with the worst kind of life events, they bounce back. I mean, with some help, but they still bounce back.
Dr. Goh, how does a caregiver know when the patient has recovered?
Mhm.
Or do we have, is it the doctor or the patient who will be the one who say, I'm already okay?
I would say all the above. Because remember, in depression, it's not just the symptoms. Depression is something that if we suffer from it, we can relate to. My mood is no longer low. I sleep better. I eat better. I can focus well. My job is fine. Okay, so the symptoms are no longer there, and this can be observed by the doctor or reported to the doctor. Doctor can ask, and the family or caregiver can also notice this person is no longer walking around in the middle of the night, snacking or turning on and off the light, disturbing me in my sleep, and so on. So they would know when they are better. Family caregivers would know. Another way of looking at it is that the distress that is reported by the person, he feels less distressed. He reported less distress to the family. He don't complain that much about his problems. He doesn't complain about feeling unhappy. He doesn't look very distressed when he sees the doctor. So distress is important. It goes down. And the third thing is the impairment, the loss of functioning at the work, at the education. Their studies pick up, their work gets better. They feel less stressed dealing with the normal kind of workload. Okay, so symptoms, distress, and the functioning.
Dr. Goh, can you elaborate a little bit more on the phrase, they control my destiny?
Is relating, I believe, to the slide of locus of control. So if an individual feels that I can change my circumstances, I can change my future by what I do today, he has the sense of locus of control, the center of gravity of the control lies within himself. So this person is more empowered. The situation they describe is other people, control my destiny. For example, this can be somebody who has not a lot of power in his workplace, not a lot of say in his family. What is to be done is dictated by the superior or another family member. No matter what he do, no matter how hard he works, he gets the same, not so much pay, or same kind of rewards, or even no rewards at all. So this is the same as experiment as we see earlier on. And no matter what is done, first of all, you don't have much say into giving input to change the things around you. Your output is not related to the rewards that you receive, and everything is just a monotonous and with little ups and downs. So this is what I meant by that.
Dr. Goh, do you still have a few minutes?
Yes, yeah, sure.
Is how many percentage of diagnosed cases is hereditary?
How many percentage? This is, I think, this is more an academic question. Percentage, yeah. I would say that there is the risk of depression being passed on in the family. That is true, but the risk is not inordinately high, and it depends on who got it. Okay, for example, if parents got it, there is a small chance that the offspring might get mood disorder as well. Sometimes a different kind of mood disorder like bipolar even. Okay, but if it's a twin, okay, get it, there's a higher chance than parent to child. Okay, if they are identical twins, it's even higher. So it's much higher than the earlier two cohorts. So it's not like twins can be sometimes can be identical, sometimes they can be different genders and non-identical. If they are distant relative, like uncle is even further removed. I would say that there are different studies and they show different percentages. In itself, the numbers looks quite high, but in effect, okay, it is actually not high. It's just how many multiples compared to the general population that manage to get depression if a relative has depression. Okay, and we know that even though I said depression is relatively common based on the World Health Organization study and IMH study, it's only a proportion, a small proportion of the population who actually gets it. I mean, you're talking about really 6% of the population.
Thank you, Dr. Goh. Some people take Anorex and Xanax before meeting performances, and this was described by the GP. Are these antidepressant, and what are the side effects?
So can you name the two drugs again? Anorex
and Xanax.
Xanax. Okay, Xanax is benzodiazepine. It's a anti-anxiety drug. So it makes a person calms down. It makes you breathe easier. Your heartbeat doesn't go that fast. You don't react that in fright to things that happen around you. Xanax and Anorex. Anorex is kind of unusual to give for somebody who is, I guess, not for depression. None of these are antidepressants. They may help, particularly for Xanax for anxiety. Anorex may have one of the effects may be to make a person calm down, but I wouldn't recommend it because it's generally it has to be restricted in its use. Some of these medicines actually cause more problems than the benefits because, for example, in Xanax, if you use too often, it tends to get an addictive picture. And the more you use it, the more it loses its effect when you really need it. So if you are really anxious and you use it for months and months, you put one in, you find that at the moment of need, most urgent need, no longer has the effect. Okay, but remember, it doesn't really make your performance better. You might be calmer, as you earlier see in the Yates-Dobson curve. If you are too calm and you work in the middle of exam, okay, there is no time pressure at all. I wouldn't say that is a good thing because you really have to be on top of your faculties in moving fast and thinking fast sometimes in certain situations.
Dr. Goh, we have several questions asking if ECT can be used to treat depression.
Yes, I didn't mention it in the talk. Okay, yes, we use ECT for in our setting generally for those of a severe kind of depression, and also for conditions like schizophrenia, usually of a severe relapse as well. Okay, so you're talking about I didn't mention it because I say relatively uncommon compared to using medication and psychological intervention. ECT is what we call a physical therapy because you have to put a small electric current on both sides of the head while the person is being sedated. It has a lot of benefits in those who really needs it. There was I remember an individual with very severe depression that as a younger doctor, when we called her in to be reviewed by us in the consultation room in the ward, we usually have to wait for 5 minutes because she would walk really slowly. And when she sat down, we had to give her a couple of minutes. When we asked a question, she would answer after a couple of minutes, not immediately. So when we had the ECT, it has a lot of dramatic effect. She started to eat, she started to talk more. In fact, the first time we saw that she was better is when she comes soon after being caught. And for the first time, we heard her say anything. And the words are, "Hello, doctor." Prior to that, she has been totally more or less mute and not talking at all. So it does have an effect on its benefits in more of the severe range of depression.
Thank you, Dr. Goh. We really have a lot of questions here. Your talk is very popular. Is there any particular reason why women have depression more than men?
That is the data from studies of the percentage of population who has depression, and it just measures how many individuals there are, men and women. It doesn't really tell us. What we wanted to know is why women may be more, it seems more susceptible to depression. Okay, I'm not sure whether it is issue with genetics, biological factors, or due to social factors. We do know that social factors sometimes can contribute. We know that for example, mothers with more than 3 young children under the age of 11 years old, sometimes they may tend to be at higher risk of having depression. So we call it one of the vulnerability factors for women. It may be more social factor at least. It may be sometimes maybe, I'm not sure whether it's hormonal or biochemical factor involved. Sometimes women who just had delivery or just given birth, they may have episodes of post-pregnancy depression, what it calls postpartum blues, or some adverse postpartum depression. But the short answer is that we don't really know why, but there can be several explanations.
Thank you, Dr. Goh. Is it possible for depression to fade for a short time and then suddenly came back rather aggressively?
So you're talking about depression symptoms going away. Okay, we call it remission. That means it goes away, and recovery. The recovery is when you go back to your former self. Okay, and the situation you described is called a relapse, when after being well for a period, the symptoms come back again. So yes, it is possible. Some people have more than one episode of depression, and this for these people with repeated episodes, where we usually strongly recommend two things. One is to stop your medication so soon after you feel better, let's say 1 week after that. As a doctor, I would usually recommend continuing the medication even though there's no more symptoms for up to a year, if it's only one episode, and then see whether we can take it off slowly by cutting the doses. Okay. The other advice I will give is that if you have more than one episode of depression, I would recommend perhaps thinking about taking antidepressants in the longer term.
Thank you, Dr. Goh. There's someone who asked, for comorbid condition that involve depression, do the person seek treatment for depression always?
Not always, but sometimes they do because they feel distressed. And as physicians, it's good to keep a lookout for individuals who may be at high risk of depression. For example, somebody with rheumatoid arthritis, we know that sometimes the drugs or even the conditions like chronic pain can cause depression. So be on a close lookout. People who has, for example, conditions like cancer, they may be at more risk of having depression. So usually the physicians, the treaters will know that this is a likelihood, and they will look out for it, and they are more prepared to identify and to treat them.
Thank you, Dr. Goh. With the current circuit breaker currently on, is it still beneficial for someone who have depressive symptoms to have a phone call or a video conference call with a counselor?
Yeah, I don't see why not, because we have been trying to do the same in INH. I work there, and so with the circuit breaker, I know there are restrictions, and we try very hard to rely on measures such as calling patients, asking how they are, and having home delivery of medication so that they don't have to come physically to the hospital. Our psychologists, instead of face-to-one, they have one-to-one giving therapy. They have actually done phone consultation sessions. There are limitations to this, but I think it's generally better than not having anything done at all.
Yes. Thank you, Dr. Goh, for that wonderful talk. And you fielded so many questions. And next week, you'll be talking about symptoms and treatment of dementia.
Yeah.
So we would be so grateful for you to come back. So thank you so much for your time, Dr. Goh.
Thank you. I hope this is useful.
The attendees. Have a good day, Dr. Goh.
Okay, thank you. Thank you.